I've got a few questions I'd love to
All
ask
right.
you today.
I may have some answers for you.
Oh,
Let's see. See how it goes.
So tell us a little bit about your practice and what you enjoy most about aesthetics.
Well, we have I think a unique practice in that our whole approach to aesthetics, I think we're trying to curate an experience for our patients from every aspect of whether it be the digital experience online, to the actual physical presence when they arrive here, and most importantly to the way they're met by the staff, and probably most importantly, like the outcomes that they're getting, right? What we're really trying to do is to allow our patients to reverse age or delay the aging process. And our view of aging is that aging is a pathological process. And it is a pathological process that affects all of our different layers of tissue. So then our goal is to first identify where is the pathology, what layer of tissue is it in, and then what tools do I have to address that pathology. So it's not the same as, oh, I have this injectable or this device, so let me use it for all comers. But it's a very sort of like, first you have to make the diagnosis, what layer of tissue or what tissue is the issue, right? And then what are we going to do about it? What tools do we have? And I think we're fortunate in that we have lots of different tools. And where I think what we do is a little bit different is we're generally leveraging multiple modalities at once. So it's very infrequent that we're doing single modality. And single modality also means, like if you're doing, say, one device and then applying different topicals like exosomes or whatever, that's still more than one modality in my opinion, right? So I think generally, ultimately, the proof is in the results, right? And that's why we spend so much time and so much energy and resources on photography, because we're trying to show incredible results while still being undetectable.
Now, photography is super important. I know that when we brought the first hair removal lasers into Australia, people were like, well, why are you taking photos? And because people would get hair removal and have like a quarter of the hair left and they would think it didn't work. You had to show them for them to believe it.
Yeah, I had an interesting patient. It was one of my first, so I used to do a lot of CO2 and then we got an erbium, and we did my very first full field erbium. A woman, she must have been in her late 60s. She had never had anything before, no injectables, no devices, nothing. So she went straight to full field erbium, and like at a month she came back and she was very upset. She said, I don't think anything's different. And I could obviously see that it was like very different. And we sat down, we did her Visia side by side. And when I showed her the results, like she started crying. She's like, this is a profound difference. But it's fascinating, this perception drift that people get of like, in her mind, because the results were gradual from her healing phase to now, she was like, I look the same. When it couldn't be further from the truth.
When you look at yourself every day in the mirror, you just don't get this wow.
Yeah, exactly.
You're just saying, what's different?
And then she got the wow when she came back for the Visia.
Yeah, it's so important. And I was actually that's one of the questions for later on, which I was going to ask, because I know you do a lot of multimodality treatments, and and I know you actually do have a special treatment that you do, but I might as well, what is that called?
Well, we have lots of different special treatments.
You do now?
But basically, so we have we have Som Neck, which is a neck tightening procedure. We have double chin dissolve, which is a non-injectable based fat reduction of the submental and jowl. But generally, so those two we actually filed patents for. But then generally, everything that we do is often leveraging more than one modality. And in particular, to me, like one of the strengths of wounding as a mechanism for repair is, that's where I think the power of Dp Derm and the Dermapen device is profound, in that you can have this very fine-tuned coagulation-free wounding that you can't really get with other devices. Even with erbium, which doesn't have coag, the erbium's not going to get me 2,000 microns deep. I mean, it could. They're not going to tolerate it, right? And so, I think when you consider the approach to something, say, like acne scarring, acne scarring is challenging, right? So, to me, the approach to acne scarring starts typically with microneedling, then with some other bulk heating device and another resurfacing device that has coag. It's these three different mechanisms, And you might think, well, doesn't the coagulation-based laser cause wounding? Yes and no, because I want to go deep, coagulation-free, leverage various topicals, whether it be exosomes or things like that, to get me more remodeling of that tissue.
Yep.
And so I think what we're doing is a little bit different, is I'm trying to think of what are the different mechanisms that I'm trying to leverage. What is that mechanism of action that it's affecting on the cell type of importance, whether it be a fibroblast or some other tissue that we're trying to either activate or turn off.
Yep.
And how is that going to get me closer to what my patient wants, which is smooth skin that's radiant and with even texture and tone and color.
So then in your experience, how does microneedling compare to other energy-based devices, like lasers?
Yeah, I think, so like if you take something, say for example, like acne scarring. And acne scarring, we see a lot of acne scarring patients, so microneedling is our workhorse. And it's partly the workhorse because of two reasons. One, the amount of wounding per square area that you're measuring can be factor folds higher than either radiofrequency microneedling or lasers. Second, with traditional microneedling, where you don't have, I can make tons of wounding to create collagen remodeling and turnover, but the downtime is mild. It's very minimal downtime. But if I then want to really aggressively resurface someone, say with laser, they're going to have some real downtime. And generally on face with acne scars, I need to go deeper than what I'm realistically going to want to do with a high density laser, right? So if the laser is both dense and deep, they're either going to have risk of scarring or serious downtime. And we live in a sunny, so do you. You live in a sunny place too. I live in a sunny place. People can't have that kind of downtime where they don't want it. So what I see is that the microneedling is doing the bulk of the textural remodeling, and then we layer in other devices that will pair nicely with that to either give some coag, to ablate some edges of the crater-like cavities, but allowing the deeper microneedling to cause that remodeling within the dermis. So you see some really nice improvement there.
Yeah. But I think people don't actually realize how many holes we're creating, particularly with the Dermapen. I mean, in less than 10 minutes, we do over 1 million holes.
And so that actually is like kind of what I was alluding to with, like, say, radiofrequency microneedling. Let's say you're doing radiofrequency microneedling and you're stamping along, even if you have good overlap, how many holes are you creating? Not a lot. So even if you do 2 passes, 3 passes, it's still nowhere near the amount of holes. And so really, radiofrequency microneedling is not leveraging the benefit of wounding. It is leveraging the benefit of radiofrequency activating and heating the fibroblasts and causing that to be the mechanism. The microneedles are just a mechanism to get that frequency in.
To bypass the epidermis.
Correct. Whereas real microneedling is actually wounding the skin to cause it to remodel. And in order to do that, realistically, you need to go deep enough to where the pathology exists and have a density of wounding that's significant enough to really cause that to remodel.
Yeah, for sure. I mean, it does my head in when people say, "Well, I've got microneedling with radio frequency. That's better."
And so,
I'm like,
and so then herein also lies the rub, right? So like, if let's say you're trying to get to 1,500, 1,800 microns of depth, because that is where the sort of parallel bundles of fibrosis are occurring to the epidermis, and you want to remodel that to make them, normal collagen bundles, non-fibrotic collagen bundles. If I'm going 1,500, 1,800, 2,000 microns deep and then delivering radiofrequency, it's actually going deeper still. And so now I'm actually causing fat atrophy. And so generally on face, I don't want to do that. So I'm, in the context of acne scars in particular, if I'm using RF microneedling, if I go too deep, I cause fat atrophy. It's not dense enough for me to get the amount of the density of wounding that I need to really cause the wounding mechanism to turn on. So if you're not careful with radiofrequency microneedling, you can actually cause more harm than good in the context of acne scarring.
Yeah, for sure. So then do you see microneedling as a gateway treatment or as it's really only standalone modality, or a bit of both?
Yeah, so I think if you look at the macro level, microneedling is probably a bit more approachable for the masses because again, it's low downtime, low risk, lower cost. In our practice, we don't really use it in that sense. We're usually using it together with other means, and so I think my practice is probably not a gateway place, but I think certainly, like, if you look, what are the gateway things, right? Neuromodulator is probably a gateway. Lip filler is probably a gateway, and I would say microneedling is also a gateway. Some of the other things that we do here, like fully ablative, non-fractionated resurfacing, is not a gateway, and it's also not for most, right? Like, most of my patients who would even benefit from that don't want to do it. So then you have to utilize other modalities and the synergy between them to create those kinds of effects. So for example, if you want to bulk heat someone, plus using your device to create wounding, you can actually do some fairly sophisticated things with that, right? And bulk heating you can do in a variety of methods. So it's interesting to think about, but what I really like about where our practice is sort of like existing at the moment is leveraging the channels that we create through treatments like microneedling to also then further allow penetration of topicals that we apply to give you now the benefit of the wounding, plus the benefit of the topicals that are going to have some other biological activity to give you even better results.
Yeah, I mean, I see such a huge movement at the moment towards biologics, whether it's exosomes, PDRN, PLLA, whatever. There's so many different biologics now, and microneedling really is the way to get them in there. So I'm seeing a huge shift back towards traditional microneedling too.
Yeah, and I think, you know, if you're only doing microneedling without these adjuncts, I think, you know, you're leaving some chips on the table, if you will, right? So, you know, I think certainly microneedling alone will give you a good result, but these channels are open, we might as well use them to our advantage, right? So, you know, whether it's exosomes or any of the other things you mentioned, why would we not use them in that context? The channels are open.
Yeah, exactly. It's the perfect modality for that.
In that sense, it is a gateway.
Yeah, exactly. What stands out to you about the Dermapen as opposed to, say, other brands?
So the Dermapen, actually, there's a couple things that I particularly like. One, which may seem like to others, like maybe they don't understand the benefit of the vibrational tip. I really like that vibrational tip for a variety of reasons, both from like a patient comfort perspective, but also from a complications management perspective. So if someone is sent to me and they have like PLLA or CAHA nodule that can't be dissolved, well, it can be dispersed. The number one device that I recommend to people in that context is the vibrational tip on the Dp Derm pen. So secondly, I love the digital aspect of the device, and to me, it's the tunability, the fact that we have a single device that's actually doing more than one thing, plus that ecosystem that you've created around it. To me, it's giving me significantly more than an alternative device in the same category.
It's a good device.
It's a very good device. It's a very good device.
Oh, you mentioned also the HLA-G exosomes. I know that you spoke about that for us once. Do you have anything to say about that?
Yeah, I mean, I think the exosomes as a category are so poorly understood still, which is kind of surprising given that there's been quite a bit of uptick in interest. Where we are today, I think, is we're starting to see that this whole category of biochemical cues remains poorly understood, and what I think also remains poorly understood is what are the long-term effects of using one source versus another. We know now, decades in, that, for example, antibody formation to neuromodulators is a real thing. And despite, you know, people having their perspective on that, to me it is absolutely true that certain patients will develop resistance to neuromodulators, no doubt in my mind. It stands to reason that any biologically active substrate will have patients who can, in fact, develop resistance patterns. So I think what's particularly interesting about your exosome product is it's looking ahead in, well, this likely is something that we should be thinking about, and what are we going to do about it, right? And I think this is giving you a solution. And again, I think people have not, the rest of us have not even gotten there yet. You guys are already thinking about that aspect, right? But I think it's a legitimate concern that we can see some either lack of potency, lack of efficacy, or not efficacy completely, like no effect over time for people who have used exosomes for some period of time if their antigenic load is higher.
Yeah, so recently you had some of your staff do some training with Dr. Andrew Christie. Was that of benefit?
When my staff went to that course and came back, it was like their skills had been up-leveled, their desire to do more microneedling had been up-leveled, and importantly, the results that they were creating in our patients had been up-leveled. And so I think from across the spectrum, in addition to creating the results for our patients, but also like it drove a ton of revenue into our practice because the device that they are using gives us great margin, right? So I think that's actually one of the biggest perks as well, aside from the fact that again its efficacy is there. And I think because we have so many devices in our practice that people are always like, oh, it's this toy and that toy, and like, sure, it's great to have lots of optionality, but the tried and true, deep, dense wounding, to me, they went to this course and they came back just like pros, and I think, I was talking to my business partner about it, the amount of revenue that they generate immediately after coming back from that course was significant.
Wow.
And it was like all microneedling.
Yeah, I mean, that's amazing feedback.
I forgot to mention, we talked about different things that we were doing with microneedling. I forgot about the most important one is melasma is a very difficult thing to treat. And the channels of microneedling are two-way channels. On the one hand, you can leverage it to get stuff in, but you can also use it to get things out. And so, for example, with pigmentation, in the context of melasma, giving the channel for egress is just as important as having a channel to get things in. And so we will often use things to break apart pigments, such as say a Q-switch device, but that pigment still needs to get out, right? And so microneedling in the context of that then allows that pigment to have a channel of egress. And so we'll usually do Q-switching to fragment the pigment, then microneedling with PRP and HA as a glide to, again, help leverage the benefit of microneedling plus the topicals, and then finish with exosomes. Did it get in there?
Yeah, I think so.
Did it get in there?
I think you got it. I think that's fine. That's fine. Fucking trains.
It's like right around the time that the trains are going to start coming. It's like 4:30.
Yeah. I was going to say something to that, but it doesn't really matter. No, it's
We're
good. You got it.
melasma.
Yeah, you got it in. Yeah. No, I know. Like, if you look at the early lasers that were actually cleared for melasma, like the 1540 from Starlux or the Fraxel, the whole idea was to create a lot of holes,
right?
To break up that pigment, and then, as you're saying, basically macrophages come and eat also, or take away the melanocytes, right? So if you think about that, you still had to deal with heat that could actually cause more melasma. So the microneedling, you were doing exponentially more holes than they were ever capable of. You're able to use it with biologics or tyrosinase inhibitors, and you don't have the heat that can risk creating more melasma. So
no heat, no light.
Yeah. So.
Yeah, and I think again, so certainly that becomes a sort of staple of our melasma treatment, right? And again, I think melasma is a difficult thing to treat. We're getting really good results right now, but again, it's multimodal, right? We're still doing orals, topicals, device. We're doing all the things, but we sequence it out in a certain way.
So finally then, if someone was looking to get into microneedling, what advice would you have for them?
Buy this device.
You heard it here first. Well, maybe not first, but you heard it here anyway.
No, I mean, I've actually had every microneedling device you could think of, and we only have one microneedling device here, and it's this one.
Well, thank you very much.
You're welcome.
It's always a pleasure, Saami.